Welcome everyone. And now that we have the rules out of the way, I'm really excited to get the talk going. But first, before we get started, I would like to acknowledge that the Rethink office is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. And now I'd like to welcome Dr. Christine Bresden. I'll say a few words about you. She is a medical oncologist treating both breast cancer and gastrointestinal cancer. And she works at Mount Sinai Hospital in Toronto, where she's the director of the Marvel Koffler Breast Center. She's also the medical director of the Cancer Center. She's also an associate professor at U of T, and she's heavily involved in clinical research. She also does a lot to promote cancer clinical trials. And I'm giving you the short version of her resume. So she's just basically a super smart scientist and also a compassionate physician who somehow finds time to give back to the community, whether it's chairing important global meetings or being a board member for My Gut Feeling, and of course for us here at Rethink Breast Cancer. So thank you so much, Dr. B, as we love to call you in our Slack channel at Rethink. Thank you so much for being here. You're also the mother of twins, and like many, recently got a puppy during COVID lockdown. So welcome.
Thanks, MJ. Hi, everyone.
How's your puppy?
He's adorable. Archie. That's what we named him. He's a golden doodle. 16 weeks old. Full in love with him.
Amazing. Well, I think the puppy's all part for a lot of people. It's just part of coping with COVID and COVID lockdowns. And just, it's been obviously a very stressful year. And I would imagine you're on the front lines, you're in the thick of it. And we thought we would just check in. It's been not quite a year, but getting close to our last talk that we did with you, kind of when this all first started. And so we're just kind of want to ask you, what's the status right now? Are you seeing now kind of delays happening or furthering, or like give us a sort of a quick overview of what you're seeing at Sinai?
So we're now officially in our third wave. So much has changed over the last year, as you all have been probably watching the news and hearing all the information and data. I think the big disappointment as an oncologist is the fact that our vaccine rollout hasn't been as robust, as we kind of watch the US. And the US is sitting on probably hundreds and millions of vaccines. And I think we'll have to wait for them to be immunized and vaccinated, but they are a neighbor. So if they have all these vaccines, hopefully they'll, our government will ensure our people here in Canada are vaccinated. And I really we are all pushing for our patients, our cancer patients, to be vaccinated. They will be rolled out in the second phase. So the phase 1, as you know, is the 80 years and older. They did a small 60 to 64 with AstraZeneca for our kind of individuals that can get vaccinated. But really for our cancer patients, we're really trying to ensure that they get vaccinated as soon as possible. So that is for our patients who are on active therapy. Breast cancer patients who have completed therapy and are on anti-estrogen therapy or being, survivors are being in follow-up, you truly can get vaccinated anytime and get vaccinated when, the time comes for you to be vaccinated. So front lines, it's always an ever-changing, information for us as physicians. But the biggest stress right now is to ensure that our patients are vaccinated so that there is protection, specifically with all these new variants that are coming forward.
One of the questions that came in ahead of time, we always go out to our community and try to gather some questions before, is, does COVID-19 affect people living with breast cancer? Is it that they're at a greater risk of getting it? Or is it, they get greater risk of getting more seriously sick? Or is it both?
So it's a good question. I think we don't have enough data to say specific for breast cancer patients. I think, for what we do have data is cancer patients on active therapy who are immunosuppressed are at a higher risk of having an adverse event with an infection. What does that mean? Hospitalized, being sicker. And of course, we don't want patients to be hospitalized in an ICU and vented and dying from this, right? So I think that's the biggest concern. And as we know, our lung cancer patients, our metastatic lung cancer patients with a lot of disease in the lungs, because that's obviously where COVID will hit in terms of creating more problems. Our lung cancer patients we're at the highest risk of being hospitalized, intubated, and dying of this. So if we move that to our breast cancer patients with metastatic disease, specifically if they have lung metastases, we always worry because the lungs are already compromised. And so we want to, ensure that these are patients that will get immunized, vaccinated as soon as possible.
How long after chemo is finished are you still immunocompromised? Like how long after active treatment are you at risk?
So that's a good question. I mean, it depends on the chemo you're getting. We'll see patients and follow up 4 to 6 weeks. And, I'm sure the cancer patients here know the neutrophil count, right? And neutrophils aren't yet rebounded. So the bone marrow is still a little bit suppressed. Theoretically, we say, there's no magic number. Chemotherapy, we look at the half-life of certain chemotherapies, they're cleared from the system by 3 to 4 weeks. But sometimes there's an effect on the bone marrow, and everybody varies. So, by at least a month to for sure by 2 months, patients theoretically are kind of back to norm in terms of their own immune system. But again, everybody is different and everybody varies. So, you can look at clearance of certain drugs and how long they get cleared out of the system. That's okay. There's no active drug, but what about the remnant effects on the body? And so that's what is variable. Younger patients tend to have a more robust and they can rebound a lot better than older patients.
Okay. Well, I think over the past year, we all became armchair epidemiologists trying to understand what these case numbers mean. And now we're all commenting on the vaccine and its rollout. However, I think our community feels a sense of urgency to try to get the vaccine. At the same time, they're kind of left with a lot of questions of what does this vaccine mean as a cancer patient? Is it safe for cancer patients? Do we have that kind of data, or are we just relying on the fact that when vaccines are tested, they're safe?
Yeah, so I mean, it's a good question. So, the influenza vaccine, for example, right? We provide that in our cancer clinic on the same day you're getting chemo. If you're coming in for follow-up, we don't differentiate anybody. We just say, get protected, right? So we will inject everybody that wants to be injected with the flu vaccine, for example. And so the same thing, this is an RNA-based vaccine, and we anticipate that it is, again, safe for patients, especially cancer patients, to get this vaccine. Is there data? There's not a lot of data. There's data that's rolling out from different countries for our cancer patients, and I think the most robust probably be from the US. But right now, it does provide a level of immunity. And so that's what you want. Now, there's a lot of questions. When do you get this? Do you get it? Can you get it on the day of your chemo? Do you need to have it a day before? There's new guidelines. So the National Cancer, so the NCCN guidelines just came out and said you get it at any time. Doesn't matter when you get the chemotherapy, you get it any time. We in Ontario have kind of said, well, we agree with that and we're following those guidelines. Some oncologists you'll hear us say, get it a few days before your chemotherapy cycle if you're on active chemo, just so that your body can mount an appropriate immune response. There's not a lot of evidence, but I think it's more for safety. The other issue is if you have a reaction to the vaccine and it's on the day of your chemo or even a day before, and you have a reaction 2-3 days after, we don't necessarily know if it's from the chemotherapy treatment you received, or is it from the vaccine? So I think those are the issues in terms of timing.
Yeah, I was reading about a lot of the side effects from that second shot. When we get there and get our vaccines, the side effects seemed very similar to cancer treatment side effects. So hard to distinguish. So the flip side of, is it safe to take, do we know that it's going to protect cancer patients? Will it work in an immunocompromised population? How well will it work? Or should cancer patients, will they need to continue to mask, physical distance, all of those types?
Yeah, until the world is vaccinated, you need to do your, due diligence. You need to mask, hand hygiene, social distancing, obviously. I think it's physical distancing. You still have to be careful, right? Now, you do have an element of protection, right? The question always is, what about the variants that are coming forward? Like, what kind of protection do you have against that? And that's where they say these different vaccines were tested probably with different variants. That's where you have an AstraZeneca percentage of, immunity and protection versus the Pfizer or the Moderna. And I think at this point, we're still learning, and it still provides that protection that you're not hospitalized, you don't have that severe sickness with a coronavirus 19 infection. So it does provide some form immunity.
Okay, what about if, we're seeing our rollout, certain things are happening where the timing between the first and second shot is being stretched? I see someone's asking, is that still okay for cancer patients,
Yeah, so we're, in terms of Cancer Care Ontario, we are trying to push for that 3-week, but many are, just based on what's available. I think in coming weeks and months, as the government procures more and more of the vaccine, hopefully we'll have less of that interval from the first to this, the booster. And, in terms of which patients are the highest risk, it really is I think your acute leukemics, it's the hematologic malignancies that are really like the bone marrow transplant patients that we really worry about the most. The solid tumor patients, like our breast cancer patients, do mount a good response.
I'm seeing a couple of questions, I'm trying to understand the immunocompromised piece from treatment. So in addition to chemo, like would something like being on Herceptin, would that be like an immunocompromising treatment?
No, Herceptin is not immunocompromised. So all your antibody therapy, Herceptin, Perjeta, that itself is just antibody therapy, so that your bone marrow is not compromised.
Cdk46 inhibitors, someone's asking about Verzenio, abemaciclib.
Yeah, so that's a good question. Cdk46 inhibitors, there is some element of myelosuppression, so your neutrophils can be dropped, but remember, it's the lymphocyte response that you're looking at, your antibody response. We don't have specific data for CDK4/6 inhibitors, but we anticipate that there is a response. Some of us are saying hold your CDK4/6, the day before, the day of, the day after, for like 3 to 5 days. It's not going to impact your care at all to hold it for a few days while you get your vaccine.
Okay, so prioritize the vaccine if you can. I think that's a nice segue. We got quite a few questions from our hormone receptive positives in our community. Always lots of questions about hormone therapy. And one of them that's just sort of came in as sort of a general question is just, could you discuss the difference between all these hormone replacement treatments that are available?
Well, I'm not the expert on hormone replacement therapy. There are different kinds. So there's these transdermals, there's vaginal, and I think, excuse me, what we're looking at Sinai, it's called our She Can Study, Sexual Health and Breast Cancer Patient Study. Excuse me, got a tickle. It's not COVID, I have a tickle. We're looking at whether or not vaginal estrogen is safe, right? And whether it's effective. And basically there's a lot of controversy. I think vaginal estrogen is probably the safest if you need to take any form of local estrogen, because the systemic absorption, what that means is how much estrogen gets into the body is extremely minimal and does not have an effect. Does not have an effect on breast cancer recurrence. And so the concern obviously is for your estrogen receptor positive patients, your tumor was driven by estrogen. So it doesn't make sense for you to take any form of an estrogen drug, a pro-estrogen drug or estrogen drug, because theoretically, there's that risk that you can be feeding a dormant cancer estrogen positive cell, right? And we know with estrogen driven breast cancers, they can rear their ugly heads 2 years, 5 years, 7 years, 10 years, 15 years. And we don't know why, 15 years down the road, breast cancer comes back, right? We know that the prognosis is better because it's that, treatment-free interval, or that when has that breast cancer come back. We always rebiopsy to say, is this cancer the same as the original cancer? But MJ, going back to your question, to be honest, you're not going to find an oncologist that's going to say, oh, you've had an estrogen receptor positive, progesterone receptor positive breast cancer. Sure, go on estrogen, right? Go back on estrogen. You're not going to hear that because of the risk of recurrence. And the fact is, in the first 5 to 10 years, women are on anti-estrogen therapy. So why do you need estrogen? Well, you need estrogen for your bones. We talk about cognition, cardiovascular health, but really it's more for vaginal dryness and all of the local vaginal symptoms. And so that's where the local estrogen can be effective, safely effective.
Okay. One of the questions that came in is, how do we deal with menopause? So young women in our community dealing with menopause in their 30s or earlier.
So menopause, well, what defines menopause, right? So young women who go through menopause, and of course, as an oncologist, I'm like, yes, I want your ovaries to be shut down, because ovaries are the powerhouse of estrogen production. It's not what necessarily I want, but for your cancer, for your estrogen-driven cancer, we want your ovaries shut down. We want to block estrogen. So you're right, you're going from a, vibrant young woman, premenopausal, and making her postmenopausal. And we have so much data to say that that postmenopausal woman is going to do better from breast cancer, right? That's estrogen-driven breast cancer is what I'm talking about.
Yeah.
And so dealing with menopause, it's multifactorial. Like what's causing the menopausal symptoms? Are you having hot flashes? So we have ways of improving the hot flashes. I can't sleep at night. The hot flashes wake me up. We have drugs for that actually are sedating and block the hot flashes. I can't concentrate. My joints, I feel like I'm 100 years old. My joints are killing me.
Yeah, someone had a question. I'm on Zoladex and exemestane. Any tips to help with achy joints?
Yeah, so yoga, exercise, lubricate those joints, move those joints. Exemestane is probably, when you look at the anti-estrogen, it is less achy, so it causes less achy joints than anastrozole or letrozole. So when I work with our rheumatologists, that's what they're saying, prescribe exemestane because it's better tolerated. So, lubricating your joints, moving your joints. And, we work with rheumatologists, we work with endocrinologists, we work with gynecologists just to improve all of the symptoms of menopause.
Thank you.
And the issue though is, I'll hear my patients say, I gotta take another drug. I'm like, sometimes yes. Like if we can get you through that 5-year, if we can get you through those first 5 years, that's the issue, is to ensure that, we get that anti-estrogen effect to prevent breast cancer. And remember, work with your oncologist. Look at the risk. What is your risk of recurrence? If you have a small tumor, it is estrogen receptor positive, talk to your oncologist, work with your oncologist to see how, do I need those 5 years? There's been some say that 3 years is effective. So, work with your oncologist.
Someone asked if it's safer if you're not planning to have children, to just have the ovaries removed completely versus shutting them down.
Well, it's a personal question. That's a very good question. If women don't want to have children, or like are 40 plus years of age, realistically, they probably will never get pregnant because you're already past your fertility years. And now we've chemically changed your ovaries and how you can get pregnant. And don't forget, when you're pregnant, your estrogen load in your body, and I tell this to my patients, is like thousands and thousands and thousands fold higher. So we don't know, we're studying this, but we don't know if you have a dormant estrogen receptor positive cancer cell, and then you blast it with estrogen from pregnancy, it can wake up and start dividing and causing problems. That's all I'm saying. And we are studying that. We had a clinical trial that we're waiting for the results. And so we're looking at whether or not, what is the duration to be off of treatment and what is the safety of getting pregnant. So back to your question in terms of, being off of estrogen, you can be off of it for, for the pregnancy study that we looked at. You had to be on estrogen for at least, on anti-estrogen therapy for about 2 years, 2.5 years, and then you can get pregnant.
Okay.
So I don't think I answered your question because I started talking about pregnancy.
And I'm seeing so many questions in the chat. Someone asked, I think they're they've moved provinces, and I know this is tricky because Canada has this provincial healthcare delivery, and it looks like, have there been any developments in the recommendation for the duration of aromatase inhibitors in younger women who have removed their ovaries? So initially I was told I would do 10 years of endocrine therapy, but was told about 1.5 years ago that they are only doing 5. This makes me nervous. I've switched provinces, so perhaps there are different protocols in different provinces.
So, duration of anti-estrogen therapy. Okay, so and I'll answer that question about having your ovaries taken out. So duration, the data changes. So there was a European study that looked at 7 versus 10 years. We risk stratify. So it depends on the type of breast cancer you had. Are there lymph node involvement? Is it a high-grade tumor? How big was the tumor? All of these paint the picture in terms of what is the risk of this breast cancer coming back. And so that's where we'll say 5 years, your risk is low. That's where we say 10 years or 7 to 10 years. There's evidence now that 7 to 10 years is the same. And so women are suffering with the side effects of anti-estrogen therapy will kind of maybe stop at 7 years. So, it all depends on how you're tolerating the treatment. What is the risk? The difference, or I'm going to go back to the previous question. I apologize, I didn't answer it properly. If a woman is post-childbearing years, doesn't want to have any more children, and has a very high risk of recurrence, so large tumor, extensive lymph node involvement, high grade, and she doesn't want to come in every month or every 3 months to get the shot, either Zoladex or whatever you're getting to shut the ovaries down, because that's a painful injection, then yeah, get your ovaries out. It is a short procedure. It's laparoscopic. It takes, the gynae docs will probably tell me I'm wrong, but it takes 15 minutes. There are, the ovaries and the fallopian tubes come out, and you're uncomfortable for maybe 1 to 2 days with a little bit of bloating because they put carbon dioxide as a laparoscopic procedure, and that's it. You're done.
Wow. Okay, one more question on this topic of hormones. I have stage 3B cancer. I'm 26. I was told my breast cancer is basically triple negative because 10% of my cells are estrogen positive and negative for other hormones. Now I'm being told I should go on tamoxifen for 5 years after I finish radiation. I don't feel like the side effects of tamoxifen are worth it, or that there would be much benefit from tamoxifen. What do you think?
So, they changed all of our, we call ASCO cap. So the pathologists kind of tell us what's positive. I agree. ER 10% was always the old fashioned cutoff. Anything less than 10% was considered ER negative. The benefit of anti-estrogen therapy is short for that specific breast cancer. But remember, tamoxifen, so your breasts have made breast cancer. Your risk of developing breast cancer is a little bit higher, right, in the future. tamoxifen will reduce the risk of breast cancer by 40% in your opposite breast. So I agree, it depends what the side effects are. And 10% isn't huge. There's probably going to be minimal benefit for that particular breast cancer. But you're right at the cusp of that 10%. You may want to, review the core biopsy. So that biopsy that you had before your surgery to the actual surgery. The core biopsy tends to be, so when you go in, you have your ultrasound, you're like, oh, there's a mass there. And they do that core biopsy. That tends to be a little bit more sensitive for the estrogen receptor because the fixation time is shorter. That's what we're told by our pathologist. So that sometimes is the true estrogen receptor and progesterone receptor. Because remember, the breast cancer that comes out is more heterogeneous, which means it's variable, right? And it depends, where that pathologist is staining and looking at that estrogen receptor. It might be a little bit less. I also like, if it can be done, looking at Oncotype, for example. Oncotype looks at the genomic assessment of estrogen, progesterone, HER2. So I like using Oncotype to actually give me a true genomic analysis of the estrogen receptor, progesterone receptor, and HER2. Just to guide us in terms of, will there be a benefit for anti-estrogen therapy? Long-winded answer, sorry.
So is that part of we should tell our community to know your type, know your score, know your Oncotype score?
Yeah, so for premenopausals, Oncotype DX is the genomic score that is used. I tend to use for my postmenopausals EndoPredict because it gives me a true benefit of chemotherapy benefit. It gives me a percentage for early endocrine therapy, so anti-estrogen therapy, and it gives me a benefit for extended endocrine therapy. But as you know, the new data that came out for lymph node positive young women, Oncotype, which is an older assay, really said every premenopausal should get chemo. I don't necessarily believe that. And that's why these newer genomic, scores like MammaPrint, EndoPredict are better because they just get a better analysis of that tumor.
Okay. I'm seeing a question from someone who's triple positive, high estrogen 80% and progesterone 70%. Do you recommend removal of ovaries?
Well, it all depends. It's a personal decision, right? So number one, it's a personal decision. You have to speak to your oncologist. What is the benefit of removing your ovaries? If you're 25, think about it, right? You might want to have children when you're 30. It's a personal decision. So I don't know how old you are. If you're, as I say, if you're 38, 40, the chances of carrying a pregnancy is very low, a successful pregnancy. And so if you want your ovaries out because you don't want to take the injection all the time, then that's a conversation you have. We do it for many of our patients. We work with our gynecologists, and as I said, they take out the ovaries if that's what you want to do. So having that postmenopausal state, we know, we have data that if you're young and you unfortunately have breast cancer and it's estrogen receptor driven, and you go into menopause with chemotherapy and you're maintained in menopause with chemotherapy, your outcomes are better than if your periods come back. And that was a Canadian study, actually.
Okay. Taking you back to the vaccine for just a second, because there's a question about, let me find it now. Should patients on tamoxifen be concerned about the AstraZeneca vaccine because of the question around blood clots?
Okay, so the blood clots has been pulled way out of proportion. The risk of getting a blood clot based on the German data is 0.004%. Okay, so it's extremely rare. In fact, some of the data, the placebo arm had more blood clots than the AstraZeneca arm. So the question is that actually protective? I'm putting that aside there. So tamoxifen, there is an inherent low, extremely low risk of developing a blood clot. That risk goes extremely high if you're sedentary, if you've traveled on a long flight. Not extremely high, I should say, if you're smoking. So smoking and tamoxifen do not go together, period. In fact, I do not even prescribe tamoxifen because of the risk of blood clots and coronary artery disease, right? So tamoxifen and the AstraZeneca, I would say probably there's, to me, based on the data we have currently, now this can change, but so I'll preempt it with this can always change, but with the data that we have, there does not seem to be
Okay.
a concern.
Thank you. I'll just take it back to pick up, someone wants to kind of pick up on what you mentioned about kind of outcomes being better if your period doesn't come back. So back to period comment. If the period comes back between chemo and the start of endocrine therapy, is that a risk? They're saying during radiation.
Yeah, so your periods have come back. It depends how old you are and what you want to do. If you want to put your periods to sleep, you go on ovarian function suppression, which is the LHRH agonist, which is that, subcutaneous depot injection. And we know that we want your ovaries to go to sleep. We want that estrogen load to be minimal, right? Your ovaries are the powerhouse of estrogen. Every time you ovulate, every time you menstruate, your levels go extremely high and they drop, right? But they're still at a very high level. And so estrogen is competing with tamoxifen. That's how tamoxifen works. It binds to the estrogen receptor, competes to endogenous estrogen. By removing the estrogen, your tamoxifen is more effective.
Okay. One more tamoxifen question. Can you explain what happens to the uterus with tamoxifen and why it's not recommended for women to have a hysterectomy before taking this drug?
Yeah, so please do not take your uterus out. You don't want to take organs out that we don't need to take out. The endometrial lining, so the uterus lining, basically gets a little bit thickened with tamoxifen. Why? Tamoxifen looks like estrogen. That's how it works. It binds to the estrogen receptor and doesn't allow for normal estrogen to bind, right? So the less normal estrogen you have in your body, the better. So estrogen looks like tamoxifen. It is good for your bones, right? It strengthens your bones because it looks like estrogen. It is considered to be unopposed tamoxifen, unopposed estrogen. It allows for your uterine lining. It's a growth for your uterine lining. So your uterine lining can grow a little bit and it grows differently. It looks cystic on these pelvic ultrasounds. So if you ever had a vaginal ultrasound, now that's where that small, extremely small risk of uterine cancer comes in. And it's been seen more for the elderly woman who has been postmenopausal for years, where there's probably some growth already. And then you add tamoxifen, so you get that growth and that changes in the uterine lining. So any abnormal vaginal bleeding in an older woman is always a concern, and we always start investigating, especially if you're on tamoxifen. But if you're young and you've had periods, that's what a period is. You shed your uterine lining. You shed it. That's why you bleed. And so the risk of uterine cancer in young premenopausal women on tamoxifen is extremely, extremely rare.
Okay, because there's a question about that. For premenopausal women who've had chemo treatment and they seem to have stopped their period, how do you know if you start getting some spotting, some pink discharge, how do you know if that's your period coming back or you're bleeding because your intercourse is painful because of the vaginal dryness you're experiencing? Or the question is, or is this uterine cancer risk?
Yeah, no, it's I'd say 90+% not uterine cancer. You just don't have the ability to form it, usually in a postmenopausal woman. It's probably trauma. So if you're having intercourse, it's probably trauma for intercourse from being extremely dry. Sometimes your periods are slowly coming back, and so you might have this pink discharge, and you'll know because you know your body and you'll know you're getting the same cramping sensation that you did. You can also test hormone levels. You can test estradiol levels, right? So that's always a test. It's a blood test, and you can simply ask your oncologist, am I in menopause? Like, are my ovaries suppressed, you can say, or we call it ovarian failure. Like, have my ovaries, have they stopped cycling? So you can always have an estradiol test, which is your inherent estrogen levels tested.
Okay, thank you. Well, our community is often balancing these competing goals of striving to maintain quality of life and doing everything you can treatment wise, to prevent a recurrence or to keep cancer from progressing. And, sometimes that burden of treatment does become, just listening to all these side effects and challenges, it can become too much. And so taking a break from treatment becomes a topic or, something they're considering. And it could be this a break from hormone therapy, which we've already mentioned, the baby time study. It could be someone in the MBC setting. And I want to just share a question we had from someone with MBC, saying, given that most women with metastatic disease will know no end in treatment, what are the risks of treatment holidays or taking periodic breaks from treatment to deal with lingering side effects? Are such breaks, especially if they become a little more frequent, are they putting metastatic patients at risk? Or should patients look to a different treatment plan with their oncologists in order to maintain good quality of life, even if the current treatment is working?
So those are all very good questions. So it all depends on what is the treatment. So if it's chemotherapy, let's go with chemotherapy. If you have metastatic disease and your chemotherapy is working, one thing we've learned from COVID is that sometimes we've increased from, like, if you're getting weekly treatment to every other week, right? So we've increased that interval so you're not beat up. Your body has an opportunity to recover, right? And that you do have a quality of life. Because those are the two, as an oncologist, these are my two goals for my patients, right? Quality of life and quantity of life, right? So that we ensure that as we improve the quantity of life, specifically for our metastatic patients, that they have a good quality of life while doing that. Sometimes there's a bit short pains that we have to go through. Because, we're a team. I'm not going through the chemotherapy and all the struggles, and I recognize that, but also, your wins are our wins. Your losses are our losses, and we're going through this together. So I think the most important is, if you need a break, it depends on what that break looks like. We can do a 4-week break, a 6-week break. Some of the patients will go on holidays somewhere. Back in the day when you could travel, and we do take a break. And we recognize that the cancer will probably grow a little bit. If you're on chemo, it will grow a little bit, but that's okay. We start back on treatment. And sometimes that break is what you need. It's like this magic time off that your body regenerates and recovers, and then you have less side effects by restarting the treatment. If you're on hormonal therapy, so if you're on anti-estrogen therapy, a Cdk46 inhibitor, or whatever you're on, if you're on anti-estrogen therapy, sometimes we need to take a little bit of a break. Being off it for 2 or 4 weeks just recalibrates the body, and if they're having a serious side effects, then you can restart. To be honest, my patients who have metastatic estrogen receptor positive breast cancer who are on anti-estrogen therapy seem to tolerate it quite well. If they're on a Cdk46 inhibitor, we work to see what the doses are, what the treatment is, what type they're on, because we have 3 Cdk46 inhibitors to choose from, right? So we work with the patient to ensure that we have the best treatment for them.
Sounds like communication is so important. Communication with your team and with your oncologist, and feeling empowered to have those conversations about quality of life and
Yeah, and you say, I want to, when COVID is a distant memory and you want to go away somewhere for a few weeks, you tell your oncologist, I really want to go on this 2-week trip with my family. Absolutely, right? Absolutely. You have to try to see if you can make that work, and you should be able to make it work.
Mhm.
You should. Why not?
And in the early setting, we talked a little bit about baby time. We know that there's enough data to run that trial because it's safe. Any comment there, if someone wants to take a break to try to get pregnant?
Yeah, so the baby time study, there's a study called the positive study. So after 2.5 years, patients come off endocrine therapy and they try to get pregnant. Now that's the piece that we don't know. So how long does it take you to get pregnant? Sometimes you can't get pregnant. So do you try for a year? And then if you can't get pregnant at that year, do you then go back on anti-estrogen therapy? We really don't know. Women who have a successful pregnancy, after they deliver, they go back on tamoxifen or whatever anti-estrogen therapy they were on. So that kind of was, we halt for pregnancy and then we go back on it. So you don't breastfeed, you go back on your anti-estrogen therapy to provide that element of protection. We have data to say that if you're young and you have to start chemotherapy, this is the big, we try to work with our fertility doctors, but sometimes the cancers are so aggressive that we want to start the chemotherapy. And there's some varying data to say, chemo and arm, should that happen right away? It depends on the type of cancer. Aggressive triple negative, high grade ER positive, high grade, dividing quickly, HER2 positives that can grow quite quickly. We try to get them on treatment within 1 to 3 weeks, right? That sometimes is not enough time to do a fertility, an egg retrieval, because when you do an egg retrieval, you have to boost high estrogen levels. And if your estrogen receptor positive, does that put your cancer at a higher risk because it just stimulates the cancer to grow? So one thing we do to help our young women is we give them that LH-Arch agonist injection. So we give them goserelin, which is known as Zoladex, 4 weeks. We give it right before, a week before they start their chemo, or 2 weeks. And then that seems to shut down the ovaries and protects the ovaries while they're getting their chemo. And so that's what we have done. And we have data to support that.
Okay.
Well, so work with your oncologist.
Okay. Yeah. Because the positive study, it's very you're in this controlled setting, you're in a clinical trial. Someone may want to just take a break. Maybe it's not to get pregnant, but a question was how long or how frequent can such breaks be, and still the benefit of preventing recurrence.
Yeah, so it's a good question. So it depends, why do you need the break? Do you need the break because you want to get pregnant? Well, that's a whole different ballgame, because you need to be off of it for a long period of time. Do you need a break because of side effects? So what we've seen, and this is all anecdotal, which means that, from our experience with our patients, is that when women are off for 4 to 6 weeks, so you just break it, and if you're my patient, you'll probably hear me say, stop it for 4 to 6 weeks. And the question is, well, is that going to increase my risk? No, not really, right? This is the estrogen story is a journey, right? It's not a sprint, as you've heard with coach, it's a marathon, right? So you stopping for 4 to 6 weeks is not going to negatively affect you in terms of your risk of breast cancer coming back. What it does do, again, it seems to recalibrate the body. So when you restart it, it's like, wow, yeah, Dr. Bresden, it's a lot easier to take it. I have less side effects. So if we can do that, that's great, right? Because we want to continue the treatment. Sometimes we do tricks, right? We say, take the drug so I always tell patients, take it at night, because if you're having some hot flashes or some joint pains, you sleep through them, right? Hopefully you sleep through them. But sometimes we have to take it around different times of the day. Sometimes, because everything is generic, it might be the generic. It might be the filler that's causing you to have diarrhea or GI upset or whatever other side effect. Change the name, change the generic brand, right? Maybe it's an EPO, try a Tiva, try the brand name. So it's a lot of different variables that we try to address to ensure that, you start tolerating the medication.
Okay, thank you. The search for improving quality of life during treatment and post-treatment, it's one of the reasons many in our community do seek support from a naturopath while they're going through treatment. And there were a few questions that came in ahead of time. One is just like really an overview. Can naturopathic options and treatment have a role in conventional breast cancer treatment? If yes, when is it generally integrated? And maybe you could just make a broader comment about that.
So we do tend to work with naturopaths, and there's just like there's different oncologists, there's different naturopaths. Beware of the naturopath who tells you that you need injections or intravenous IV therapies. That is a naturopath that is probably not doing you justice if you're on chemotherapy. And we know who is on naturopathic drugs because they're actually more immunosuppressed than normal. And what are the common ones? High dose vitamin C infusions. You're paying money for nothing. Honestly, it's ascorbic acid high dose. You're actually peeing it out. It is an acid and it's putting a load on your kidneys. Mistletoe injections is another common one. That is a big no-no, right? It affects your liver. And guess what? Your chemotherapy needs a good liver to be effective, right? To be effectively metabolized and killing your cancer cells. Mistletoe, and we see it, puts women at risk because it makes them more immunosuppressed. We see rapid drops in your red blood cells, your hemoglobin, your white blood cells, and your platelets, which will help you clot. So we already kind of get an idea. We'll ask you, are you sure you're not taking anything else? And the last is mushroom extracts. Mushroom extracts can be very toxic to your liver, extremely toxic to your liver. And guess what? Your chemotherapy works by your liver, right? So that's how it makes it effective. So please be very cautious what you're taking. Please be honest with your oncologist and with your pharmacist. And we have naturopaths we work with, and they know what patients can and cannot take. And this is when you're on active chemo. So I always say, please don't take anything while you're on chemo. The chemo piece is that if you're in the curative and you're just taking it because you were just diagnosed with breast cancer and you're going for cure, please don't take anything. Be a virgin. I want your liver and your kidneys to be virgin. I want them to have their own innate power to deal with all the side effects, because I know the side effects. When you start mixing in all of these drugs, and they're drugs, they'll say, oh, they're naturopathic. No, they're not. They're drugs. Mm-hmm. They're not Health Canada approved. I have no idea where they come from. Anything, you can get a beautiful bottle. You can get these drugs synthesized in pills. You don't know what the filler is. You don't know what's in them. You don't know where they're made. Yeah, it looks good. Your naturopath is telling you that it's good. But it's not approved by any regulated agency, which is the issue. So this is where, and obviously they cost lots of money. So this is where we have issues. It's not because we don't have data to support it, but it's because we see our patients suffer, right? So guess what? I have to drop my chemotherapy dose because your liver numbers are too high, or because you're immunosuppressed. And so you are negatively affecting your chemotherapy, your breast cancer, your known breast cancer therapy that has been studied in probably now millions of women. Mm-hmm. And you're doing it because someone has told you that, oh, this is going to work. And trust me, we see it all the time. Mm-hmm. And we know that our women are seeking as much support that they can. But please, again, work with your oncology team, which your team is your oncologist, your pharmacist, your social worker, your drug access navigator, your nurses. Work with your team to ensure that you're not causing harm to yourself by taking some of these medications. And work with your naturopath. So your naturopath and your oncologist should speak. And that's what I always say. If someone's on, I go, please, here's my card, have them contact me. And then we have a dialogue, right? So that they know what you're taking. They know what I'm prescribing. Sometimes you'll see a patient will come, and my colleagues, my oncology colleagues will say, yeah, I don't deal with naturopaths, right? I don't deal with naturopathic meds, because the patient will come with a whole laundry list of drugs. And the oncologist will say, I'm not prescribing this. So go to your naturopath and ensure that that is safe. I'm not going to be reviewing this, because I'm telling you right now, no, stop it. And so that's where I think the issues arise in terms of having that dialogue, because there's the oncologists have seen it over and over again that there's harm, and so they say stop. We will interrogate all the drugs and say, yeah, take vitamin D 2000, absolutely. Yeah, take vitamin C 500 milligrams. Sure, that's not going to affect it. There's a question I think on turmeric. So turmeric and tamoxifen. So let me go back to tamoxifen. Tamoxifen is, I call it a dirty drug, in the sense that it is metabolized in the liver, and it affects a lot of different enzymatic pathways. So you can't, eat grapefruit or drink grapefruit juice. You can't eat, Seville oranges. You can't take a lot of naturopathic drugs, such as turmeric, because it affects the enzymes in the liver again. St. John's wort, forget about mistletoe. So all of this really affects the liver. Tamoxifen, you have to be so cautious, even if you're taking antibiotics. Your pharmacy team, who is giving you the tamoxifen, will tell you, you can't take, we have to give you this type of antibiotic, because tamoxifen will interact. So it just likes to play in the sandbox with all the other drugs. And so it will affect the efficacy, the toxicity of other drugs and itself. So that's why you have to be very cautious if you're on tamoxifen.
Okay. One last question on this topic. Someone, says I take quite a few supplements in my daily routine. I'm curious to know if certain supplements have been linked to causing breast cancer. So now we're getting even further from interfering with treatment, but actually, is there a potential causal link? Sounds like you're saying they haven't been studied, or supplements that I should be avoiding. Currently, I'm diagnosed with high-grade DCIS, non-invasive, so will not be requiring radiation or chemo after mastectomy. So there's not a concern for supplements interacting with treatment at this time, but still is curious, is it something still to be cautious about?
Well, it depends what you're taking, right? I mean, be very cautious. Naturopathic drugs are not studied. They're not regulated. So I don't know what you're taking. I don't know. Does it come from, who knows, where is it made? Where are these drugs synthesized? In what facility? What are they using as fillers? How is it regulated, right? So you can be causing sometimes more harm than good. So do I take vitamins? I'll push it on myself. Of course I do. I take vitamin D, like 2,000 units a day. I take a vitamin B complex. And if I'm feeling unwell, I'll take some more vitamin C. I'll upregulate my vitamin C. And I'm being honest, this is what I take. But, still, when I look at my vitamin B complex, and I don't take omega, I probably should. But when I look at the vitamin B complex, it's called Sisu. It's a regulated company that makes the vitamin. And so it's a challenge. It's hard to navigate this space. It really is, because there's so many drugs out there, and I call it, my vitamin B6 complex is a drug. You can call it a vitamin, but still a drug. I'm taking a drug. My vitamin D is still a drug. It's a vitamin, but you're still ingesting things into your body that may or may not help you, and actually may be harmful. I don't take mushrooms. I don't take any of these extracts. I am very cautious about them because of the experience we've had. I'll never forget, I was a resident, and we had a young woman who came in when I was a first-year medical resident. She was a young woman who wanted to lose weight, and she was given this mushroom extract from somebody, maybe a naturopath, and she died on us. She died of liver failure. She died rapidly. We couldn't get her to transplant. So I've painted this picture in my head. Now it's my experience. And then when I see all of the effects now with chemotherapy, and we're seeing liver numbers because, you know, the chemo can affect the liver, and then that's compounded because someone's taking other medications, I am very cautious. I get very nervous. And so that's why I say, please stop all the extra things that are probably not benefiting you at this time. You can start taking the supplements when you're finished your chemotherapy. I can tell you the radiation doctors will not want you to take absolutely anything. They don't even want you to take vitamin D because, you know, you heard of, oh, I'm going to take antioxidants. You want oxidation. When you're on radiation, you want the oxygen to work. You don't want antioxidants. So every radiation oncologist will tell you stop all supplements while you're getting radiation. And then you can start them afterwards. But I'll, again, be cautious. Work with your oncologist, work with your naturopath. I mean, I'm not saying naturopaths aren't good people. I've got good friends who are naturopaths, and we have discussions about this many times because sometimes there is truly a benefit. And I just say it's complementary, right? It's a complementary approach. And remember, many chemotherapies are naturopathic. Paclitaxel came from the bark of the yew tree. Erubulin is from the sea sponge in the ocean, right? You've got drugs that are naturopathic already in terms of if you're thinking they're coming from a natural source. They're synthesized now, but.
Okay, but that was the original. Oh, wow. Okay. So I think there's room for one more question, and then we'll wrap it up. So does grade matter for MBC? I'm stage 4 de novo, highly hormone positive, HER2 negative. Do I fall into that category of responding well? I had a hysterectomy 2 years before diagnosis.
Yeah, I mean, it depends. Obviously, so it depends on where the breast cancer has metastasized to. You know, we know, so the good news is strongly estrogen progesterone was positive and de novo. You know, typically it is only in the bones, typically, but I could be wrong. Women can, you know, live for years with good anti-estrogen therapy. We have Cdk46 inhibitors. We have new SERDs, so fulvestrant, which is the bum injection. Some of you may be on it, which is takes the estrogen receptor and downregulates it. Now there's oral SERDs, so instead of having a bum injection, it's a pill form, and they're being tested now. There's so much research going on. It's great. So many clinical trials.
I was going to say, I feel like we'll need another whole session just to talk about the robust pipeline and all these new treatments.
Which is so exciting.
Yeah.
So it depends, to be honest, it depends where the cancer is, if it's in the liver or the lung or the bones. It all depends what the response is. And typically there tends to be a good duration of response with de novo disease.
Okay, well, that's kind of ending things on a positive note. One final question, just to leave us with, you know, lockdown is lifting in some parts of the country, vaccines not here, the variants are there. What are kind of your parting words to our community as we navigate the third wave, which you said we're in for sure?
Yeah, so just be careful. I mean, I think, you know, some of us have young kids, some of us, you know, have you know, elderly parents. We want to spend time with them, spend time with friends. We, you know, it's been a tough year, right? It's been emotionally very, very tough. You know, just hand wash, you know, be careful. I don't have to preach to you. You've all been doing it. You've been living it for a year, you know, mask up. And hopefully by this time next year, this will be a distant memory. And, you know, we'll be able to hug our neighbor. We'll be able to get on a plane safely and travel to a tropical island and enjoy ourselves or visit family abroad. I think, you know, it's been tough, but, you know, you're all warriors. We're all getting through this. And hopefully we are all advocating. I can tell you, I sit on, you know, a lot of committees. Cancer Care Ontario is working hard. Our head, Lita Forbes, was just at the vaccine table on Monday. they're working hard to get our vaccine for our patients. We are strongly advocating to get our patients vaccinated. You're not forgotten. We are, as I said, really trying to get our patients protected. But in the meantime, protect yourselves.
Thank you
And
so
stay
much.
positive. Stay positive. This is a very important organ. I say it all the time to my patients. Your brain, your mood, everything. It's an important organ. So keep it positive as much as you can.
Thank you. Thank you for taking time. I know it's been a long, busy year. Thank you for being here and bringing us all this information and, bringing us this rainbow that's
My
behind.
son took this. This is a true rainbow at the cottage. I was saying he was fishing and it just finished raining. And he said, Mom, look. And I went, wow. So I took a picture. I've never seen a rainbow from end to end. And it was incredible. So I thought, you know what? There is a light at the end of the tunnel. There is the rainbow. And hopefully the pot of gold will be there with the end of COVID.
Hopefully. So thank you everyone for being here, for asking all your questions, for sending them in advance. Thank you, Shauna, for firing the questions over to me and organizing everything for this great session. And I hope everyone has a great night.
Thanks, everyone. Stay safe.
Bye.